Hello everyone, thanks for the introduction. It's really great to be here. I'm going to be talking about MR elastography, which can be called mechanical neuroimaging, and how it can be used to map the viscoelastic properties of the human brain. So I was kind of told that maybe not a lot of people will be familiar with the technique, so I'm kind of going to go over the basic concepts of what it is, how you perform a brain MRE exam, talk about the kind of clinical applications, as well as looking at studies that have assessed the kind of mechanical structure and function relationships, and also just a little bit about how we can improve data interpretability. So MR elastography, or MRE, was first described back in 1995 by researchers at the Mayo Clinic. And it was first discovered how to record the propagation of acoustic waves into an image. It's a non-invasive phase contrast MR-based technique that uses low-frequency mechanical waves to quantify the viscoelastic mechanical properties of biological tissue in vivo. And this mainly includes measures of tissue stiffness and viscosity. And it's regarded as being palpation as a physical property is being measured. And we know that manual palpation has had, it's been great at detecting diseases for centuries because physicians move their fingers across the tissue and they can feel the shear the shear deformation, which kind of identifies nodules, lumps, or tumors. So obviously there's problems with that because as a physician, it's very subjective and it can be quantified. And of course, if you want to look at other organs like the brain, can't palpate the brain because of the skull. So this is a new way of measuring the same properties. So currently the main clinical use of the MRE is assessing the degree of scarring due to liver fibrosis or cirrhosis. And that's because numerous studies have shown that liver stiffness increases with collagen accumulation. And stiffness measurements do corroborate with biopsy proving liver fibrosis and cirrhosis. So it means that MRE is sensitive for staging liver fibrosis. It can guide treatment decisions and also determine the likely response to treatment. And increasingly, it has begun to replace the need for liver biopsies, and particularly in the US, where a lot of hospitals now use this approach. And that's kind of represented by the fact that there's 16,000 clinical installations of this MRE equipment. And of course, if there's more people who have the technology to perform MRE, there's going to be more scope to perform other research studies to look at other organs, such as the brain. So very briefly, this is how MRE is performed in the liver. Hopefully it'll just give some context. So a mechanical actuator is used to introduce shear or sound waves into the body. And the second step, the sound waves that pass through the tissue are visualized with an MRI sequence. And finally, the displacement images are converted to mechanical properties using an inversion algorithm, which is a mathematical reconstruction. And that's to quantify mechanical properties, including stiffness and viscosity. So, as I mentioned, numerous studies kind of show liver stiffness increases with collagen. So here in the very first, on the top row, you can see a normal liver tissue and the waves are propagating through and there's a mean stiffness of 2.1 kilopascals. In this particular patient, the liver looks normal. However, you can see that the kind of waves are longer, which means there's a stiffened material, and that's represented by a mean stiffness of 4.8. And actually that when the biopsy was performed, it confirmed stage 1 or 2 liver fibrosis, which you wouldn't have detected in this image. And then with chronic liver disease, you can see there's a huge jump. And actually now there's kind of established thresholds for stage 1, 2, 3, 4, and for cirrhosis. So it's become very standardized. Right. So the main advantage of MRE is how it measures the shear modulus, which varies over several orders of magnitude. So from zero in blood to hundreds of megapascals in ligaments and tendons. And the main idea is that it's a technique sensitive to tissue microstructure, capable of detecting the macroscopic footprint of these micromechanical interactions. So here you can see, you can visualize both untreated and cross-linked collagen using microscopy. And uncrossed collagen is a viscous material, more liquid than solid, and it exhibits a very low shear modulus. Whereas the kind of cross-linked collagen is a solid with shear modulus in the kilopascal range. But the cross-linking that occurs between these two images, so from state 1 as a fluid, state 2 as a solid, is not visible using microscopy, which is madness. Well, it makes sense, and that's because microscopy is not sensitive to these subtle structural alterations which occur within fibers. Instead, if you use MRE, it is able to measure this 30-fold increase in tissue stiffness between the two states. So the quantification of the viscoelastic behavior of soft tissues provides information on the mechanical integrity of multi-scale tissue structures that will vary significantly with health and disease. And just on this slide here, I just want to show how MRE is sensitive to subvoxel structures. So wave scattering from the application of shear waves during an MRE scan is incredibly sensitive to microscopic obstacles. So on the mesoscale, which bridges the molecular and the macroscopic scales, wave refractions can occur at interfaces as small as a single hair, which causes interference that translate into visible contrast into the MRE images. And in the kind of MRI high resolution image, which was a 0.125 voxel size, that small, very, very tiny structure is not resolved. And so this figure just really illustrates how MRE can be used to detect very subtle tissue alterations. So moving on to brain MRE, and the first thing to address is how to generate shear waves in the brain. So MRE always uses an external mechanical actuator to generate deformations. And for brain MRE, since you can't touch the organ, you need to vibrate the entire head. So you vibrate the head, the brain moves relative to the skull, and it generates these shear waves on the surface that they propagate in. The amplitude and vibration is very gentle, it's very fast. Most research groups use vibration frequencies of 50 to 60 hertz, and the amplitude of the skull is tens of microns, so it's being moved very little. So throughout the history of MRE, people have developed their own actuators. There's a review there which kind of discusses the pros and cons of each type of actuator design. But the pneumatic device developed by a company called Resounding, shown in this image, is the only one currently approved by regulatory authorities. So in the setup, acoustic energy generated by the pneumatic driver is transferred through the tube, and it vibrates the back of the head through that soft pillow, which is known as the passive driver. It's very easy to use, very robust, which is great when working with clinical populations. So I think the availability of something like this helps with the standardization of brain MRE and helps the advance of brain MRE through its availability. So a question you always get asked is like, well, how safe is this? It happens time and time again. So I'm really glad that this work's been presented this week at ISMRM. So very early studies obviously checked the safety, and it was well below any kind of vibration limits. But given the expanded interest in brain imaging applications with MRE, this study conducted a more comprehensive assessment of vibration exposure with the brain MRE driver, the pillow. And that's because I think there's around 50 pillows being used worldwide, which is kind of been a massive jump in the last couple of years. But in this histogram, you can see the root mean square acceleration for each subject, and it's well below 8 meters per second squared, the maximum value suggested by the EU 2002 directive. So the motion generated by the actuator is synchronized to the MRE imaging sequence, and the harmonic excitation should ideally be continuous, and time is given to allow the material to reach a steady state before sampling. So MRE encodes harmonic motion into the phase of the MRI signal, and typically in MRI we're looking at the magnitude signal, which contains the anatomy, which is clearly more often used. But you can also capture the phase of the signal as well, and in MRE the magnitude instead is used for registration and tissue segmentation purposes. And MRE is quite standard really for a phase contrast sequence, but one thing you do is you use frequency selective motion encoding gradients, and these are shaped to one frequency to tune to that type of motion that is applied. And you apply gradients on all three axes so that you get a complete 3D representation of the displacements or strain rate at every voxel. So this means the MEG, the motion encoding gradient, is toggled along 3 encoding directions. So that's the phase encode, slice encode, and the readout. And that's to capture all orthogonal components of the wave field. And what is also essential for MRE is to change the synchronization in time, and that way you can capture how the waves propagate. And because it's harmonic, we construct these complex full vector displacement fields. And in this image here, you can see that there's 8 time steps throughout the harmonic cycle, which are equally spaced. And these images here, they show the displacements in each direction. So you have the head foot, the anterior posterior, and the left right. And what's interesting here is that when we're using the pillar, we expect these displacements, but we don't expect left right because we're vibrating the head like this. But it's still you still expect some left right motion, and that's why it's really important to capture the 3D strain. So essentially any kind of sequence can be adapted for MRE. So this has been gradient record echo with or without API, spin echo with or without API, as well as spiral sequences. And one of the main disadvantages for API sequences is that they are susceptible to significant distortions. And that's because the entire range of phase encoding steps are acquired in one TR, which leads to a long readout time. And one of the imaging sequences I'm most familiar with is the so-called multi-band, multi-shot spiral sequence, which was developed at the University of Delaware and has since been applied in numerous clinical studies. And this is where coverage is divided into multiple slabs or slices. The fewer number of volumes means a shorter TR that is near optimal SNR efficiency. Both in plane and through plane parallel imaging can be achieved due to the high SNR, and also phase error correction can be performed through micrometer echo. And these kinds of sequences are really important when the aim is to obtain high resolution displacement images, particularly on a 3T scanner. And at the moment, the resolution, we're looking at a resolution of 1.25 isotropic in approximately 10 minutes. So after we obtain the raw phase or the displacement images, they must go through several processes prior to analysis, and that's to remove any unwanted noise. So while we need a sufficient amplitude of vibration to produce waves deep into the brain, too great an amplitude can cause this heavy phase rep. And this is when the amplitude of the wave shifts by more than, the phase of the wave shifts by more than 2 pi. So you can see the heavy phase rep, which mainly does occur around the edges of the brain. It's quite easy to get hold of phase wrapping algorithms. There's been quite a few publications, there's software available, but that's also quite an active area of research. So then the next stage is for the phase images to be temporally Fourier transformed. And that's to obtain the frequency domain complex displacement field and to isolate the harmonic motion of interest. So the Fourier decomposition greatly improves the consistency of MRE data because non-harmonic motion, such as breathing, can obviously affect that signal. So it's also essential to remove longitudinal waves, as they can contribute to the total measured displacement field. And you can use high-pass filtering. You can calculate the curl of the vector curl of the measured wave field. And this essentially removes the low frequency bulk waves and leave only the remaining shear waves that you're interested in. And because the compressional waves, they travel so fast that there's not a kind of way to capture this at the moment. So it's also important to examine whether the displacements are sufficient quality to undergo this kind of reconstruction. So a really popular method is called the octahedral shear strain SNR, and it literally gives you a value which shows whether the measure of strain is sufficient and will give you good enough quality data. And we know that the measure of strain rather than motion provides a more reliable measure of the quality of the data. So the last step is the material property estimation, where we estimate mechanical properties from the displacement fields. So the higher the underlying stiffness, the higher the speed, and the longer the wave at a given vibrational frequency. And this is a process we call inversion, or using an inversion algorithm. And generally that's performing an estimate of the solution to the inverse problem from the time harmonic Navier equation, which is described here. There's a lot of assumptions that you make to kind of reduce the complexity of that equation. And ultimately the outcome is the complex shear modulus. So you get the storage, which describes the elasticity of the material, and the loss modulus, which describes the viscosity. So this is, the wavelength traveling through, and the loss modulus is more about the wave attenuation, which describes the kind of viscosity of the material. There are many different inversion algorithms, but they're basically all solving the same basic equation, often with these simplifications for computational reasons. So this is a very active area of research. There's no kind of universal agreement what is better, of course, but there are three fundamentally different physical concepts. So these kind of methods, you're looking at the spatial frequency of the wave, or the wavelength, the wave speed. This is where you insert, you can simplify the Navier equation down to the Helmholtz equation, and it's relating the displacements to physics motion. And then you also have the finite element models, which use a finite element model, and that's called nonlinear inversion. So I'm mostly familiar with the FE-based optimization method, which was developed by collaborators at Dartmouth College. And so the way that it works is that you take a finite element model mesh of the brain, break it into subzones which are overlapping small chunks of the brain, and assign them an initial guess of properties. You then calculate what the displacements would be through that subzone based on the properties and based on boundary conditions that you get from measured data. And then properties are iteratively updated until displacements agree with the initial model estimate. And the concept is basically about minimizing the difference between the two. So both global and local iterations are performed to ultimately reach this global solution. And there are several benefits to using NLI. One is the use of a heterogeneous viscoelastic model, which is the type of model that allows for spatial varying properties. And of course, that's really important when you consider the brain, which is the two different tissue types, of course, have different mechanical properties. It's a bit different for the liver. You can use a more simplified inversion because the liver is largely homogeneous. So, I think for the brain, you should consider something like this. But there is also a new recent development, which is quite interesting. And this is the use of artificial neural networks to the inversion. And this was developed by the Mayo Clinic group. And it works by taking simulated wake data, different underlying properties, and making hundreds of thousands of simulations in small patches, training a network that is then able to predict what the properties are. And this kind of approach can account for edges as well by training the network to estimate the mechanical properties in the presence of missing data. These graphs clearly show that the neural network inversion has improved performance to the regular direct inversion that was often used, and particularly if you were looking at smaller structures. The simulations show that this is more accurate. In a later paper, the neural networks were trained on inhomogeneous data, which is called inhomogeneous learned inversion. And here you can see, and there's a brain mimicking phantom, it more clearly picks up these inclusions compared to the earlier neural network inversion and the old inversion. So you can see that there's progress being made there. And finally, I think that's what I want to say. Oh, apart from that, it does provide this higher contrast to noise as well. So another complexity about MRE is the number of different tissue parameters often reported. This is not even a complete list, but generally you either get properties that are expressed from the wave point of view, so its speed or attenuation, or from the materials point of view, so the complex shear modulus. Each could be interesting in their own way, but they often have different noise sensitivities. But there was a kind of meeting about this at the ISMRM a couple of years ago, and it was like, how do we kind of standardize this a bit more? What can we do? And so this is a great paper, the white paper published in MRM, but essentially they recommend to report certain pairs of parameters to capture the full viscoelastic behavior. So that could be the storage and loss moduli, the magnitude of the loss angle, and the shear stiffness and damper ratio. This is essentially the same thing, and going into it would take far too long. But so moving on to clinical applications, there's been a lot of interest in brain MRI because it offers a completely new biophysical contrast of brain anatomy, which of course will be of interest to anyone looking at it. So I don't have time to go through all of the applications that have been done, but first I want to discuss how MRE can be used for neurosurgical treatment planning, and this is because actually it has been used now. The surgeons at the Mayo Clinic are using MRE as part of their kind of clinical workup. And then also there's a really interesting study that came out recently about whether MRE can predict tumour progression, so I'll briefly discuss that. And then my own area of interest in MRE is in aging and biomarkers for Alzheimer's disease. So I'll talk a bit about that as well. So what we know is that the consistency of a tumour has direct implications for tumour resectability and prognosis. So, for example, soft meningiomas are a bit like toothpaste. They can use suction to get them out, whereas hard meningiomas may require like a much more invasive procedure, resection, and ultrasonic aspiration. And I remember reading this book a couple of years ago, and it said it's impossible to know how soft or hard a tumour may be, but it'd be great to know this because it has such a huge influence on the surgical procedure. I thought, well, this technology is available. Why is it not being used? But anyway, the preoperative knowledge of tumour consistency can help, as I said, guide decisions, whether minimally invasive procedures can be used. It can also tell you about how adhesive that tissue is to healthy brain tissue. And it also, you can communicate the risk to the patient. If it's really adhesive to healthy tissue and there could be a risk of loss of function, whether that be hearing or vision or whatever, the surgeon can kind of make that known to the patient, and they can decide whether we actually need to radiation. So these are all important factors to consider. So then last year, a study by Shi and colleagues at Shenzhen Hospital performed a prospective study to examine whether MRE stiffness was associated with tumour consistency determined by the surgeon's evaluation. And this study's been performed quite a few times already, and there's always been really high concordance. But for the first time, on the extracted tissue, they performed a histological analysis. So this is really interesting because you can see a grade 1 meningioma in the right frontal lobe, and you can see kind of two distinct areas. You know, the contrast on any of these images don't show or distinguish any part of that tumour as being different from the other. But MRE instead indicates this kind of tumour heterogeneity. So in the anterior region, it's firmer, and the posterior region, it is softer. And then there was hematoxylin and eosin staining confirmed how there was a greater tumour cellularity and fibrous content in area 1, which is, you can see here. So this lines up with this lines up with this. So you think, wow, okay, this is going to take two different types of instrument, etc., to perform this successfully. So MRE did outperform other imaging techniques in distinguishing fibroblastic meningiomas from other histotypes, but there was a problem with the kind of very small tumours where there was these inconsistencies. But overall, there is substantial evidence that this preoperative evaluation with MRE can characterise this spatial heterogeneity in tumours. But as I just discussed a little bit earlier, there is that neural network inversion that recently came out. And it was applied to this case of a stiff meningioma. And you can see that the ILI inversion, so the advanced neural network inversion, sharply separates tumour boundaries, and there's a sharper stiffness transition than the other inversions evaluated. And the previous study that I just mentioned, they use this technique, where we know from all kinds of results and simulations that this is much better. So when we think now about looking at smaller tumours, actually, this could be a lot more reliable with this method. So moving on now to brain tumour progression. This study here looked at two different types of tumours. So you had your glioblastoma multiforme and your meningioma. And they're both completely different tumours with different clinical prognosis, outcome and treatment options. Meningiomas originate in meningeal tissue, they grow slowly, and they often have these edges which you can visibly see. But instead, glioblastomas, they grow rapidly, they diffusely invade the surrounding tissue, and it's really difficult to localise the tumours because they don't have those boundaries. But overall, you know, glioblastomas are grade 4, very poor prognosis, with a high risk of the short-term reoccurrence after surgery. But here you can see that in the meningioma case, the tissue is, the tumour is fairly soft compared to reference tissue, and it's highly viscous. In comparison, if you look at a glioblastoma, it's even softer, but actually it's more elastic than viscous. So glioblastomas are softer and more solid, and theories from fluid mechanics suggest this may actually contribute to why glioblastomas are so aggressive, invasive, and can infiltrate surrounding tissue. So in the same study, they performed two separate experiments of phantoms of tofu embedded in heparin or vice versa. And in both sets of images, the enclosed material, the blue, is intended to mimic the tumour's infiltrative behaviour. So in the bottom row, you can see how the low viscous heparin is pushed into the surrounding highly viscous tofu, which mimics the behaviour of a glioblastoma, which I just showed is less viscous than the surrounding tissue. So this kind of environment favours infiltrative growth, which is predicted by the framework of the Self-Man-Taylor instability, in fluid mechanics. So overall, this fluid behavior induced by different VCM compositions in normal and abnormal brain tissue seems to provide an elegant solution or an elegant physical explanation for the highly different invasiveness of these two different tumor types. So moving on now to the kind of biomarkers for healthy aging and disease. Before any imaging technique can be useful as a biomarker of disease, it's important to understand normal brain changes in healthy aging. We know that older age causes both structural and functional changes to the brain. But in one of the earliest MRE studies by the MRE group in Berlin, they found that the kind of global brain softens in older age. And this is actually one of the more robust findings in MRE. Several different groups always, we always report the same thing, which we'll see on the next slides. And then through animal models, we know that this reduction in stiffness is shown to reflect a kind of loss of the strength and the composition of the neuronal glial matrix. In this study, they also reported how brain softening occurred at a faster relative rate than brain volume loss with aging, which is interesting because it suggests that MRE measures may be more sensitive. But instead, the viscous parameter was actually fairly constant, and that kind of suggests preservation of the organisation of the neuronal connection. But like I said, just looking at the brain as a whole, this is when the resolution wasn't quite as good. So we're missing these important localized effects, and particularly specific anatomical structures undergo rates. So with higher resolution imaging, the ability to map regional properties is improved, and this really helps when we consider looking at specific structures which are responsible for certain functions. In brain MRE, high resolution MRE is an active area of research. It involves improvements to the sequence, the inversion. You can use multi-frequency MRE or you can use higher field strengths. But essentially, the improved MRE acquisition and processing pipeline we were able to, not me personally, the Mayo group, they were able to look at the lobes of the brain, and it was reproducible to within 2%. And what's interesting is that, the frontal, temporal, occipital, and parietal lobes, they all show this decline in stiffness, but not in the cerebellum. And that kind of it shows that the measures are specific, because we know that the cerebellum is one of the last regions of the brain to show signs of aging. And then a study that I used the kind of multi-band sequence I was talking about, and the resolution was 1.6 millimeters at the time. And complementing previous studies, we found that the majority of structures were softer in older adults, with large effect sizes found for the caudate thalamus and putamen. But importantly from this study, we were able to show how these effects persisted even while controlling for volume size, which suggests the additive volume of MRE property measures. Again, we found no differences in the viscosity parameter, either globally or in any structure, and I'll come back to that in a second. So during my time in Delaware as a postdoc, I worked with a PhD student, Peyton Del Gregorio, and we designed a specific MRE protocol for assessing the hippocampal subfields. We know that each subfield is uniquely sensitive to disease, and it could pinpoint regional vulnerability and better understand hippocampal pathology in the early stages of Alzheimer's disease. So this protocol, we used the multi-band sequence again. We got the resolution to 1.25 millimeters. And due to this increase in resolution, we were able to tweak the parameters in the NLI inversion to improve the repeatability and sensitivity measures. So we made adjustments to the SPR alpha weighting, the soft prior regularization weighting, into a setting that promotes mechanical homogeneity within a predefined anatomical region, so within the hippocampal subfield mask. And we made changes to the spatial filtering width, which controls how much smoothing is applied. But as is the case with NLI, you need some kind of regularization because of data model mismatch, which I'll discuss a bit later. But so we kind of balanced the combinations to decide on the optimal protocol with the greatest repeatability, and sensitivity. And so there's little consensus about which subfield is primarily affected by aging. It changes which paper you read. So we hope that MRE could be highly sensitive to capture differential age-related effects on subfield integrity. So first of all, we were able to show that the subfields had distinct mechanical properties, which is in line with the fact that we know that they are distinct cyto-architecturally. And we also demonstrated the subfields soften with age, but they actually appear to soften at a different rate. So, for example, the CA1 region has a stronger relationship with age than the spiculum. Similarly, for the damping ratio or the viscosity parameter, there's a uniform increase in subfields indicating greater relative viscosity. And this is the first time actually in aging that we see this change in the viscosity parameter. And is this because with this high resolution approach, we are able to pinpoint very specific regional vulnerability? So now moving on to MRI studies that have examined neurodegenerative disorders, most commonly been Alzheimer's disease. And the first study was back in 2011. And it was the first study to kind of globally look at the brain and say, actually, there's a softening of 7% in Alzheimer's patients, and they were biomarker confirmed. And I think initially it was quite surprising because people thought, wait, they've got amyloid, so the brain might become stiffer because amyloid plaques are, they are stiffer than normal brain tissue. But if you think about the fact that beta amyloid plaques are discontinuous and actually only form a relatively small volume fraction of the entire tissue, the effective stiffness of such a material will be dominated by changes in the softer matrix. So anyway, so it's suggested that MRE may be more sensitive to the downstream neurodegenerative effects, and that lower stiffness may reflect degradation of the extracellular matrix, loss of normal cytoskeletal architecture, and or altered synaptic connectivity. And then a year later, the kind of initial observation in humans was replicated in a mouse model, in which the brain stiffness of APP-PS1 mice was lower compared to wild-type mice. So I think that gives some confidence in what we're seeing. So again, with this kind of enhanced methods, why is it changing? But MRE was used to assess the integrity of the hippocampus in 2017. There was a larger change in the hippocampus of 22% lower stiffness, but they also looked at the thalamus and there was no kind of change there. So again, that points to a specificity of MRE to detect differences in regions of interest. The diagnostic accuracy of AD was also improved with the incorporation of hippocampal stiffness with 2 other MRI-based hippocampal parameters. So that was volume and mean diffusivity from diffusion imaging. And that had a combined ROC curve of 0.9. And then in 2020, we published a study again with a high resolution again compared to this, where we looked at the viscoelastic properties of the cerebral cortex. And we found it was a voxel-wise analysis, and we found that brain tissue softening in AD was localized to specific areas within the parietal, frontal, and temporal cortices. And that included the middle and superior temporal gyri, the precuneus, precentral gyrus, and the opiculum. But these results were then confirmed in MRE native space afterwards, so that was reassuring as well. But interestingly, the spatial patterns of lower stiffness was not the same as the smaller volumes of AD. So we performed a VBM and a VBM MRE study. So it kind of suggests that MRE might provide indication of changes to tissue integrity that aren't spatially localized to volume loss. And actually, we found MRE differences in the frontal cortex that had not yet shown signs of volume loss, which raises an in-question issue of timing. So does the microstructure alterations observed by MRE precede the macroscopic volume loss? We don't know the answer to that question, but it shows promise for MRE to possibly monitor disease progression, but longitudinal studies are needed. I don't have time. And this figure just kind of emphasizes the need for high resolution. So there's a summary of MRE in aging and neuroimage a couple of years ago. So here you don't, if you look at large regions, you don't really see this kind of large effect. Again, if you look at the thalamus and the hippocampus is a much greater effect. Again, if you look at the cortex, you see, and this is where the pathology lies. So then we performed a study with patients with mild cognitive impairment, so the prodromal stage of Alzheimer's, and we found that these two regions has affected MCI, AMCI, but not the other two. And again, we found the inclusion of the stiffness improves the classification beyond volume alone or stiffness alone. So combined CA1, CA2, stiffness and volume. Stiffness is represented by mu. So this is positive. And another thing we quickly looked at was, can MRE identify MCI in those without hippocampal subfield volume loss? So if you have a low volume, so you've got atrophy, volume loss, okay, lower stiffness does predict the possibility of an MCI diagnosis. But what I think is really interesting here is this quadratic trend, which shows that actually these people haven't undergone any tissue loss yet. However, if you begin to see this lower stiffness occur, they're much more likely to have this condition. So actually, is this, telling us something, a process, that can be separated in time? In another study by the Mayo Clinic group, they examined brain stiffness change across the cortex in 6 different clinical groups. So this is healthy controls, amyloid negative, positive, positive amyloid with MCI, and this is your typical Alzheimer's classification, dementia with Lewy bodies and frontotemporal dementia, and it was whether different patterns of brain stiffness could help with differential diagnosis. They looked at 15 different grey matter regions, and you can see, yes, differences for various dementia groups compared to the control group here do show different patterns of brain stiffness in the cortex. So frontal temporal dementia was associated with the largest and most widespread changes in stiffness. Not so much in dementia Lewy bodies, but it's actually quite, again, this is, you're not seeing any differences due to amyloid. So it looks like MRE isn't sensitive to amyloid. And actually it could be much more likely to be tau, or we don't know. But again, these, if you look at the kind of standard clinical condition of Alzheimer's disease, precuneus, this one, presentral, this was all the kind of regions I reported in my 2020 paper. So this is really reassuring. And just to quickly touch on mechanical structure function relationships, the first study relating viscoelasticity to cognition was performed by Hilary Schwab, a collaborator at the University of Illinois. And it was initially a proof of concept study. They were administered a behavioral task, a spatial reconstruction task, which is a sensitive measure of relational memory. And it's usually sensitive to hippocampal volume in older adults, but not in young, healthy adults when there isn't much variation in volume. So, but in this study, a strong association was found between SR task performance and hippocampal damping ratio. So essentially, if the hippocampus behaves elastically, relational memory performance is better. And this was actually replicated in a larger follow-up study. And I performed a study in older adults where we saw exactly the same relationship, and I used a verbal paired associates task. So that's really interesting. And the lack of relationship with volume suggests that this dampen ratio measure is more sensitive to hippocampal structure. And then again, Hillary in 2017, she looked at the relationship between aerobic fitness and memory and found that hippocampal viscoelasticity played a mediating role between greater aerobic fitness measured with VO2 max and greater memory function using the same SR task. So these results kind of suggest viscoelasticity may provide an imaging marker to examine the mechanisms behind this relationship between the two. And while these results obviously show considerable promise for examining the hippocampal memory relationship, we also kind of think, well, looking at wider brain mapping approaches, does this kind of relate to other cognitive domains as well? Could we find the same? Could we find this in another function? And so, yeah, that happens to be the case. Here you can see if you looked at the dampen ratio of the hippocampus with spatial reconstruction, you see a strong correlation. But then if you were to look at the hippocampus with a different task, which is a figure series task, which is reliant on the orbital frontal cortex, which is a measure of fluid intelligence, you don't see that correlation. But here you see a strong correlation with the orbital frontal region, with the figure series, but not with the not with the spatial reconstruction task. So, and that forms a double dissociation. So that gives really good, like, strong confidence that these are selective and dissociable structure-function relationships. So I'm sorry I'm running out of time, but finally is the question you always get asked is, what is the underlying biology of the MRE signal? And there's been animal studies that look at these kind of things, and there's been a relationship. But I think it's really important to consider this will change with the application that you're looking at. So this, of course, is what we saw in the histology stains if you're looking at meningioma tumours. So it's not a one-size-fits-all approach. And I think this was a really great study from the Berlin group, because they looked at the viscoelasticity of the mouse brain during development. They had a proteomic analysis, and actually during development at separate time points, they found that the brain stiffness increases, and this is, the histological changes that occur, which, there was this direct relationship. Viscosity-related tissue fluidity decreased, and there was down-regulated actin cross-linking. So that was a really cool study. And actually, if you think there's this fluidity decrease, this matches quite well with, so there's just starting to be MRE studies in children and in development, and you can see there's fluidity decrease as well during this time point, and you can see that different structures have different trajectories, but you can start to think about how actually some of these things might be linked to what you're seeing in the image. And just finally, there's more work looking at multi-excitation MRE and the ability to recover the anisotropic properties, because the mechanical properties aren't going to be the same in each direction. So this helps reduce data model mismatch, so it will improve resolution, but it does require more parameters to be estimated. But with DTI, you can get your secondary and your primary and your secondary fibers. We know a lot of fibers are crossed, and then you kind of get your standard imaging parameters, shear stiffness, dampen ratio, but also tensile and isotropy measures as well, which could be useful in certain diseases. So to summarize, brain MRE is a novel way to assess brain health. It provides a macroscopic footprint of these micro-mechanical interactions. There's been a continuous technical development over 10 years. It's now high resolution, reliable, robust, and reproducible. There's still lots to be done. And I've just got a welcome fellowship to explore this further. It's only started a couple of weeks ago, but It's to look more broadly at how the mechanical environment affects biological systems. So my interest is in Alzheimer's disease. So this is whether mechanotransduction contributes to AD development. And this is just one of several theories, but do we see this kind of change to cells and ECM breakdown? Does this contribute to glial morphology, which is what this process here is? And we're also collecting blood biomarkers of amyloid tau and neurofilament light, forming diffusion MR spectroscopy to look at glial morphology. And this will be in people who are high risk for Alzheimer's disease in midlife. So hopefully using kind of causal inference statistics, we might be able to work out the chain of events that occur. Thank you, and happy to take any questions.
To the audience to see if there's any questions.
One question, very nice talk. I was just thinking of the application on cancer. So you were mentioning fluidity. So I'm not sure, do you think that it would be better just to have a proelastic model instead of a viscoelastic one? Or that
Well,
specific?
it's tricky. Do you mean like a poroelastic model where it's biphasic, so you model the solid phase and the fluid phase? Yeah, the problem is with that though is that it's only really possible to look at the poroelastic properties at very low frequencies. So at 1 hertz, and you can use something called intrinsic activation, which measures the very, very obviously low frequency. And but at 50 to 60 hertz, it's too fast to pick up on the porous phase. So you can't do it with this kind of technique. You would have to do intrinsic activation in MRE.
I have one question about the imaging time of the MRE. I wonder if it's possible to combining the imaging and the inversion algorithm together in the MRE.
Well, yeah, I guess so. With liver MRE, because it's a clinical product now, you perform the scan and the inversion's done on the computer console, so you get your map of tissue stiffness up straight away. And any areas that you don't have high confidence in the displacements are crossed out. So it's all kind of automatically done for you. Brain, it's a different story. It's like I think actually now when they sell the resounding, they do that, but I don't typically use that sequence because they usually use about 2 millimeter, but I'm using like a 1.25 multiband, which you have to reconstruct offline. So there's no way you could get the inversion on the scanner console.
Thanks for the talk. I was wondering about the viability of the measure, like throughout the day, and maybe because you talk about memory, was it like do you measure like MRE just after a memory task, for instance? Does it affect? Yeah, can we?
Sorry, what do you mean? Sorry.
I mean, how variable is it through the time? Like, if I measure you now, your MRE is gonna do an MRE scan now, and
oh right, yeah. So for like the so the repeatability, do you mean? Yeah. So it depends what size structure you look at, but for kind of subcortical structures, it's like between 2 and 6%, which is well below any kind of change you see in disease. And then I did a kind of simulation study to look at the accuracy of cerebral cortex measurements, and it was in the same ballpark.
Okay, so
if you see,
for instance, I was thinking if you have a task, for instance, to see how the MRE changed like before the task, like at rest.
Oh,
after a memory task or like a sport task, I don't know.
There has been a study on that. It's in review at the minute. It's where we did an acute exercise. So it was only about 20 people, but they either kind of rested or did, I forgot what the name of the task is now, but it was like a lot of like star jumps and things like that. And there was this acute change in tissue stiffness that then correlated with a change in memory as well.
Right.
I also have a question, a follow-up on the functional MRE study that you talked about, right? Do you have any more thoughts on that? Like, do you know what they are actually detecting? Like, what? Because I think that the claims in the paper is that it's actually that the changes in stiffness happens prior to the changes in the gold signal.
Yeah, that's completely different from what I've just spoken about.
Okay, all right.
But
Okay.
it's you know, this is like structural functional MRE is used more obviously now. You would use it if you were looking at similar tasks in fMRI.
Yeah.
I don't know too much about it because it is fundamentally a different technique.
Yeah.
Yeah. But yeah, supposedly is 60 times faster than the volt signal.
Yeah.
The changes in tissue mechanics is like a visual stimulus. You can detect
exactly.
changes in the occipital lobe. Like,
There was just one thoughts on that. What's the like? Do you trust it or?
I think so. Just because there's been a few groups now that have found similar results.
What's on the mechanism?
Again, hard to say. Yeah.
Excellent.
For the changes in white matter with aging, you show there's also increase of the spaces. Basically just for CSF then around.
Well, we've not really looked at white matter because of this problem with the isotropic assumption in the inversion, but with so it's kind of something that people have shied away from in recent times. But in the last slide here, if we can start to use the fiber direction from DTI, especially the two primary and secondary fibers, it relaxes some of these assumptions. So be more able to have like a reliable measurement of white matter tracks, which we haven't had previously. Does that answer your question?
Yeah, thanks. And the other question would be a bit on the reconstruction algorithms. I mean, you didn't touch too much on it, just saying there are big differences. But then you have a better one. How are you really sure it's closer to?
So during my
because you saw quite intricate differences in hippocampus, then you need a good resolution.
Yeah.
But
so
construction artifact sometimes which you see.
so during my PhD, I assembled 3 different MRE protocols that were used worldwide. I performed phantom experiments and brain experiments, and was very much like swayed by my results on a particular pipeline. I haven't showed this data, but yeah. It was a Cirrus phantom with 4 stiffness inclusions, and the kind of the multi-band LI approach had very good accuracy.
I mean, depends a bit on how local your inversion problem is you have to solve. What we saw in conductivity phantoms for our MRCDI is that they're actually not very useful because they are too simplified in the geometry.
Yeah.
So then they fit quite nicely, but by days, inversion algorithms don't work out.
Yeah, no, I wish I had a slide of the simulations I performed. So I used a realistic brain model of and you know looked at specific regions of the cortex that are affected primarily in Alzheimer's disease, and even reducing the boundaries and things like that. It was the ground truth, and the recovered was excellent. And that was just my study, but the people who work on this on a daily basis, like, they come out with it's very well validated on their side. The engineers.
Any other questions? Yeah.